First, I'd like to thank the organizer and specifically the chief of the board, Professor Paul Green, for inviting me. It's an honor. I have to explain you first a bit my viewpoint. At one leg I'm a clinician and on the other leg I'm a physiologist. And I see everything what can be learned from elite performance, from athletes of exercise. How can I apply to the much larger group of subjects that have problems related to it? First, let we try to compare brain and skeletal muscle a bit. Well, first of all, the brain is active when under all living conditions, even when we sleep, because it controls our respiration. I have patients, as soon as they start sleeping, they stop breathing. Second, when you start exercise, usually you do it in the upright position, but the transition from supine to upright is already a problem, because a postural change that affects brain blood flow. Because the central blood volume drops, and you are accumulating here, and the system is perceiving that blood pressure threat is starting to drop, and this is happening. This is the blood pressure at the level of the brain circulation is lower. Your cardiac output is lower, and so standing up means sympathetic activation with increasing heart rate and vasoconstriction, systemic vasoconstriction, so to say. What is the consequence for the brain? Well, it's not only that is the transcranial Doppler determined velocity. The mean velocity is a bit lower when I stand for about 5 minutes, but also my cortical oxygenation by near-infrared spectroscopy. Actually, it was found for the first time by Scheinberg in a very invasive way. It has been proven actually. So actually, the problem is here. The problem is here that standing alone, just that, makes the pre-test condition for wherever you go a bit worse. The oxygenation is low. So the best thing is for oxygenation is to keep supine. But it's not always possible. And then, versus compared to the skeletal muscle bed, the brain is very small, but it is strongly regulated by what we call autoregulation, although we do not understand quite what that is. And among others, the partial pressure of arterial carbon dioxide. That's not all. There are other ones. Apart from the effects of oxygen and carbon dioxide and autoregulation, it seems that there is a neurogenic control of the circulation. We assume that. It's a kind of secret. It's a theory. Sometimes we see something, but we didn't prove it. I come back to that. That is the effect of the endothelium itself. And then a strong one, the coupling. That is, the neurovascular coupling actually has to do with it. Is a certain brain region is activated that it needs blood. Because neural tissue, when neurons start working and synaptic traffic costs a lot of energy. So you need blood for that. First on carbon dioxide then. This carbon dioxide, this is blood pressure. It is someone who is standing in the upright position and start hyperventilating. You see that at blood pressure swings. This is mean velocity in the cerebral artery, not the total velocity, and this entire CO2. It takes about, when I start hyperventilating now, it takes about 12 seconds, and then I can do it very easy. My cerebral circulation, my perfusion is about half, and I feel a bit dizzy. You can do that in. About autoregulation, it assumes that changes in pressure, in cerebral perfusion pressure, and well, for easiness, we take blood pressure accounting for the level from between heart and the brain. An autoregulation, what it does, according to this scheme, this relationship between pressure and blood flow, to keep blood flow relatively constant. Often you will see in textbook that it is a horizontal line. It says it is maintained for working pressure between 60 and about 140 millimeters mercury. It's not horizontal. That horizontal line has been determined in earlier days in a large group of subjects, but not in one group. So it was plotted and then they got one. But it's not, and of course not, because in biological systems, the gain cannot be infinite. So it's not a horizontal line. Autoregulation is a bit, well, it's not that easy, but it's clumsy sometimes. What we do in the lab, that is the Aslet maneuver. It is, what we like to bring about is a drop in blood pressure, a change in blood pressure. We do that by releasing muscle cuffs. And then you get a drop in mean pressure by the enormous vascular vasodilatation. And you see the mean cerebral artery velocity, but it is earlier. So here's the lowest point of blood pressure, but this point here already starts autoregulation. Then you can make a plot and calculate the rate of autoregulation. That is one side. But you can't do that with patients because it is painful. You can't do it with stroke patients and so on. The other one is that, but it takes a lot of time. You have to do it by hand. You look in long recordings on spontaneous swings. We all have those spontaneous swings in blood pressure. That was done by Roger Immig. He did it for up and down. This is blood pressure. Blood pressure goes up about 20% in 10 seconds. And this is cerebral blood velocity. And what you see is that for the first 4-5 seconds, it follows passively. It seems to follow passively, and then it goes down. This is autoregulation, and so for a 20% increase in pressure, it's only 5% in velocity. But it is a slow system. Slow to say, it takes some seconds. And then brain versus muscle. Brain's only 2% of the total body weight, but it takes, at least in rest, 20% of its oxygen consumption. Well, I indicated earlier, as soon as synaptic traffic starts, it costs a lot amount of oxygen and substrate. So in the neighborhood, capillary, astrocyte, and the synapse together, this is the unit that makes it. But you understand that to let it work, you need oxygen, you need glucose, and the brain uses lactate. This is neurovascular coupling. And then the muscle can down with its saturation very low in still function. The brain stops function when it is more than 10%. And all this, it seems new, but it was already described and reported by Lassen. Metabolic, chemical, carbon dioxide, oxygen, autoregulation, and then the question mark. And the question mark is about the sympathetic effect. And we would like to get rid of that question mark, but it's not easy. And then activation. Activation of brain by exercise that enhances cerebral blood flow. That was demonstrated in the early 1990s. This is the velocity. This is hand gripping. This is the left cerebral artery, means middle cerebral artery, left hand grip. And what you see, that at the right hand grip, does more to the left because that is the crossed projection. And it is, can you repeat? So it is a kind of local activation. Earlier, it was Lassen again with an ingenious device where you could make, together with Ingvar and Skinhøj in Copenhagen, very nice pictures, actually detailed. And what he showed was that the effects of exercise are rather heterogeneous. So it's not global, it's localized. And that makes a problem. The problem now is that blood flow measurement in no single artery or vein can be considered to really say what's happening to blood flow. It's not blood flow in one vessel. That is what we do in our lab. We use this one, both, maybe together with near-infrared spectroscopy, but it's just small parts of the whole brain. So here you see when we would like to advance our insight, you need scanner. And that's difficulty in itself. And then we come to sympathetic effects. That's the question mark from Lassen. Because the role of sympathetic activation for brain blood flow is controversial. We know it's a dense innervation of all the small, the medium size, but all the larger vessels. And we know that when you that the drainage of the brain, that the reflex spillover, there's noradrenaline spillover. So there should be sympathetic activity somewhere, but we can't locate it. And well, this is just a preliminary result. It was done earlier, but now we did it. Well, we did it. It were the people from Leiden University at the MR Center with the 7 Tesla. It showed for the first time that sympathetic activation by hand gripping in the magnet, in the coil, reduces the diameter of the artery a bit, and it's repeatable. It's not too much, moderate exercise, only 2-3%. They thought it was interesting from another point of view. So Doppler is not functioning. They say, well, 3% is not important, but you have found now that there is vasoconstriction. They didn't know that was important. Then we shift to the heart. The heart itself has an effect, the heart-brain axis. It has, in healthy subjects, relationship between cardiac output in rest and during exercise, beyond blood pressure. But it was found earlier in patients. And that was found from the group from Bengtsaltine, patients with heart failure, moderate heart failure. What they did, they measured leg blood flow and cardiac output with 1 leg exercise and 2 leg exercise. I have to explain to the figure this cardiac output. First, the patients here. The patients are represented with the open symbols. These are the healthy subjects. And then 1 leg exercise are the open, are the circles and the triangles. That's 2 leg exercise. The cardiac output for the healthy subject is simple. One leg is doing this. When you exercise with 2 legs, cardiac output is up. This is not happening for the patient with heart failure. Here again, the healthy subject's leg blood flow is up. 1 leg doesn't make it goes up. This is 1 leg in the heart failure patients. When they add a 2nd leg with that cardiac output, leg blood flow drops. So it explains that there's a shortage of blood. It's not pumped, there's not sufficient pumped out. And then the question was maybe also for the brain. And that was what they did. They showed it again early in 96. So the same group of patients, that 1 leg exercise, blood flow to the brain was maintained. But if you add a 2nd one, then there's not sufficient blood is lower. These are the controls. And to be certain that it is not hyperventilation because it is strenuous to these patients, they showed that carbon dioxide levels did not change. And that brings me that there seems to be a competition between the brain and working muscles when we consider where the blood is coming from. And that is the weird situation that the brain is the strong regulator. It activates the muscles, but when the muscles start working, they are actually competing for provision of oxygen, and that can be very large, very large. So the brain starts something it didn't think of. I think it was Raoul who called this phenomenon waking up the sleeping giant. There's large muscle mass. So heavy exercise with large muscle groups requires more blood than the heart can pump out. And that brings me to, may it be that cardiac output, if it is low or if you can't increase, may contribute to a lower cerebral blood flow. This is exercise between young and older. This is mean arterial pressure. The young are the closed circles. You see a lower blood pressure, but the same increase. A higher heart rate increase. Here the systemic vasoconductance is larger, and here the cardiac output increase is lower. This is healthy old versus young. And this is what's happening in the brain. And there are 2 things. The first is that of course, the elderly have a lower increase in velocity. But the second thing is that, and that is a general pattern, also the healthy subjects have this shape. They start exercise, blood flow increases about 23-30%, and then they exercise more and strenuous, athletes, everyone, and then it declines. That is this curve. This is typical. Of course, conduct is different, and at a lower, they hyperventilate a bit more, the elderly. Then about brain versus skeletal muscle extraction. That's from the work of Gonzalo Alonso and Calvet. What you see is it is interesting with exercise, with maximum exercise, the difference across the legs, and here the difference across the system, the circulation, it goes up very high. But extraction also across the brain, well, the maximum extraction is about 50%, 48 I think, with the scatter. Keep that in mind when we turn to patients. So it seems that exhaustive exercise evokes deoxygenation in the brain, and all the metabolic changes and the indices of fatigue, the Borg scale, they are very similar to what may be observed when you let people exercise under hypoxic conditions. And then, so that is one theory, and it is difficult to base a debate that reduced cerebral oxygenation may play a role in development central fatigue. And central fatigue then defined that it is no longer possible to activate the muscle, whereas if you activate the muscle directly, or directly with nerve stimulation, or by transcranial stimulation, then the muscle can do the work. Then it seems that the brain has become the weak component in exercise. And then it is a limiting factor. And now from the viewpoint of patients who should enjoy exercise to get themselves better, exercise in patients with diabetes, type 2 diabetes. This is the protocol actually. Blood pressure, resistance, heart rate, and here the velocity again. Bouts of exercise followed by stopping. You see very low blood pressure. Sometimes we had to advise them to pedal on because it was only too low. So when this is both absolute and relative values. From a clinical point of view, I like this one. From the physiological leg, it's this one. That's interesting, but both are nice. So the diabetes, the closed circles, the control, the open circles. Heart rate, stroke volume, cardiac output, mean arterial pressure, and systemic vascular conductance. You see the difference. That is a lower cardiac output, a lower stroke volume, lower cardiac output, and a lower vascular conductance. That is the general picture. Mean pressure is not too different. So if you look at heart rate and pressure, almost no differences. But beyond that, it's deemed different. And the wear capacity of this group was about 80% of the maximum, and cardiac output increase, also a difference of 80 versus 100%. This is lactate and rate of perceived exertion. Again, absolute and relative. Here you see for every workload, they are a bit more fatigued. And they reached higher lactate levels early in the exercise. In relative values, it's comparable almost. And then brain. And we did it in two ways. This is the transcranial Doppler velocity, and this is cerebral blood flow by Fick with oxygen as indicator. And the assumption with oxygen as indicator is that the brain oxygen consumption is constant. We think that is for the first part of exercise that is pretty nice, but in the late part the brain oxygen consumption increases. So for this part we think it's fine. This is the healthy subject again. That is the Fick, and that is the same subjects, the transcranial Doppler, and then now the subjects, and that was disappointing. They do not develop the physiological increase in cerebral blood flow during exercise. They actually drop immediately, and do it here, and they do it also in the transcranial Doppler. So in the early stage of exercise, these middle-aged men who used to train actually, they were Danish, I think 3 times a week an hour or 2 hours biking, so they like to show what they're good. This is what's happening. They were not complaining, but that is what we measured. And, well, these are measurements of oxidation and saturation and another one. They all differ during the whole process. They are lower than the healthy subjects. And then we try to make some metabolic measurements, and no difference for lactate, for the cumulative index for lactate, for glucose, for everything. So it is not metabolic, and that is what I thought, but it is circulation, it's confusion. And then the extraction ratio, the control of the diabetes, and the end, you see there's a trend, but the scat is large and the number of subjects was small because it was an invasive study. You could not do that in too many, but it seems there's a trend that the diabetic patients have a larger extraction in the later stages, then it becomes statistically significant. This is the background for everything, for everyone here. So, beware. This is die Abhängigkeit des absoluten Hirngewichtes von Lebensalter getrennt nach Geschlechtern. This is what the volume and the body of your brain. It's a German publication. They see men and women, it declines. It starts decline early, actually. So your cerebral perfusion also declines between the 30 and 50 years. In 20 years' time, it declines already. Now we go to exhaustive exercise in the middle-aged diabetic patient. A limited cardiac output reserve and work capacity, an early reduction, although lower cerebral blood flow, a larger extraction of oxygen, and enhanced fatigue. It seems what is described when people exercise in hypoxia. And this is hypothesis, this is health. So as long as you have a cardiac output, you can perfuse the brain and your muscles, and then the brain can recruit the muscles. In diabetes, probably a lower cardiac output, lower cerebral blood flow, and then maybe suboptimal recruitment. Difficult to prove. And I told you, well, we have to go to the scanner, but the problem with the scanner is that you have to exercise in the horizontal position, the supine position. So that is what we did. We just finished this study without a scanner, but just in the lab, upright and supine. You see that in the supine position there are differences, not in the first part. Heart rate and cardiac output do their work. It's nice. Pressure in the supine is larger. You hyperventilate, you start earlier when you're supine, and for the brain there are also differences. So it is not that easy to translate it, so what you see in the upright position to supine. So then about training, this is a last part, resistance exercise training that should, well, it does it in the leg, increases vascular conductance. And the question is this also true for the brain? Well, indirect evidence. We know those who continue work or maintain physical activity when they retire, they have a better cerebral perfusion. That has been done, better cognitive tests. There's a strong association between fitness and performance and brain blood volume. Gray and white matter volume may increase or be maintained with this, and then from animal experiments, nice, another one. So now it has become the time to train large groups of middle-aged and older people without and with cognitive. And now this disappointing publication, that is, in a large group, almost 2,000 people, 2 years training, published in the JAMA last year, a 24-month physical activity program, nothing happens. It did not result in improvements. But if you read it, the methods, the methodology, it would not have been accepted by a physiological journal if the referees were awake, so to say. And then always, when someone sees that, there was Marc Poulin who did it, then a letter is not read. And now, what he said is, well, it's a polite, but it could have been more of. We have concerns about the working definition of moderate intensive physical activity, the implementation, monitoring of the intervention, because you should be under supervision for 2 years in all the people, on everyone. And then the density of the, it's useless. But the problem is, and that is my environment, I have a clinical environment, my colleagues say, exercise. Well, have you seen the publication, the JAMA? 2 years, nothing happens. How to neutralize that? So now I'm looking at the younger ones. It's your task to change that, to challenge that, to interfere. And, well, write letters, 10 letters to the JAMA. And then maybe they will accept you as a new referee, and we can get rid of it. This harms, so to say. So the grand challenge we are waiting for. Let's discover, this is for the young ones, when and how sympathetic stimulation modifies brain blood flow. You should be able once, I don't know how, define the relation between hypoxia and what is called central fatigue. And then, please, develop a strategy that proposes the early declining brain blood flow and oxygenation during exercise. Then they can exercise better and the diabetes gets better. Thank you.
Thank you, Johannes.